I'm Dr. Elena Vasquez, and I spent 22 years as a neonatologist at Harmony Children's Medical Center in Phoenix, Arizona. Or at least I was, until I submitted my resignation 8 months ago. Most people in the NICU just called me Dr. Vas during my time there, and I've seen everything you can imagine in neonatal intensive care. Micro-preemies born at 23 weeks, babies with complex congenital heart defects, triplets fighting for survival in overcrowded wombs, and every kind of miracle and heartbreak that comes with the delicate beginning of human life. But what I'm about to tell you about is the one case that made me question everything I thought I knew about the boundaries between life and death, consciousness and medical impossibility, and ultimately led me to leave neonatal medicine entirely. Harmony Children's Medical Center sits in the heart of Phoenix's medical district, a sprawling complex of glass and steel that serves as the premier pediatric facility for the entire Southwest. Our Level IV NICU is one of only 12 such facilities in the western United States, equipped with the most advanced life support technology available and staffed around the clock by specialists who dedicate their lives to saving the smallest and most vulnerable patients imaginable. The unit itself is a 92-bed facility that handles the most critical cases from across Arizona, Nevada, New Mexico, and parts of Utah and Colorado. We regularly care for babies born as early as 22 weeks gestation, infants whose organs are so underdeveloped that their skin is translucent, their bones are soft as cartilage, and every breath requires mechanical assistance. These are babies who could fit in the palm of your hand, whose entire circulatory system contains less blood than a tablespoon, and whose survival depends on machines that cost more than most people's houses. During my 22 years at Harmony, I attended over 4,200 high-risk deliveries and supervised the care of countless critically ill newborns. I've seen babies born without kidneys survive through revolutionary dialysis techniques. I've watched infants with hearts the size of walnuts undergo successful open-heart surgery. I've held families as they made the agonizing decision to withdraw life support from children whose brains had been too damaged by oxygen deprivation to ever support conscious life. In neonatal medicine, you learn to balance hope with brutal medical reality. You fight for every life, while understanding the stark limits of what modern medicine can achieve. You become an expert at reading the subtle signs that distinguish a baby who will beat the odds from one whose fight is already over before it begins. You develop an almost supernatural ability to predict which tiny patients will surprise you, and which ones will break your heart. Or at least I thought I had developed that ability, until I met baby Sophia. The case I'm about to describe began on what seemed like a routine Thursday evening in March 2023, March 9th, to be exact. I was finishing my evening rounds, checking on our current census of 37 babies, when our emergency transport dispatch received a call that would fundamentally alter my understanding of what's medically possible. The call came from Dr. Rebecca Winters at Desert Valley General Hospital in Flagstaff, about 2.5 hours north of Phoenix. Dr. Winters was someone I knew by reputation, a solid emergency physician with 15 years of experience who had rotated through our NICU during her residency. She was not someone given to dramatic overstatement or medical hyperbole. Her voice when she called was tight with an emotion I couldn't immediately identify. It wasn't the usual urgency of a physician dealing with a critical case. It was something more complex, confusion mixed with disbelief, and an undertone of something that almost sounded like fear. Dr. Vasquez, I have a situation here that I need to transfer to your facility immediately. It's a single baby, born at approximately 24 weeks gestation, but the circumstances of the delivery and the infant's current condition are unprecedented. 24 weeks is at the very edge of viability. Babies born at this gestational age face enormous challenges. Their lungs are barely developed, their immune systems are virtually non-existent, and their neurological systems are so immature that survival rates hover around 50 to 60% even in the best circumstances. Every case is critical, but they weren't usually described as unprecedented. What are the specifics, Rebecca? I asked, already mentally preparing for another complex premature infant case. The mother is Isabella Moreau, a 31-year-old artist who moved to Flagstaff from New Orleans about 6 months ago. She was 24 weeks and 2 days pregnant when she went into sudden catastrophic labor at her home studio around 4 p.m. today. I was making notes, calculating approximate transport time and preparing our team for arrival. Any precipitating factors, infection, trauma, drug use, none that we can identify. Isabella is healthy, no medical history, normal prenatal care, no complications until today. Here's where it gets unusual, Elena. When the paramedics arrived at her studio, they found her unconscious on the floor. She had delivered the baby completely unattended and appears to have lost consciousness immediately after delivery. Unattended delivery at 24 weeks is extremely dangerous for both mother and baby. Without immediate medical intervention, the chances of infant survival are minimal. How long was the baby unattended before paramedics arrived? Dr. Winters paused, and I could hear papers rustling in the background. Based on Isabella's neighbor's 911 call timeline and the paramedics' response log, we estimate the baby was without any medical assistance for approximately 35 minutes. 35 minutes. I felt my stomach tighten. For a 24-week premature infant, 35 minutes, without respiratory support, temperature control or cardiac monitoring is typically fatal. The baby's lungs wouldn't be developed enough to sustain independent breathing, and premature infants lose body heat so rapidly that hypothermia alone can cause cardiac arrest within minutes. Rebecca, what was the infant's condition when paramedics arrived? This is where it gets impossible to explain, Elena. When they found the baby, she was lying on a paint-splattered tarp next to her mother. No pulse, no respiratory effort, core body temperature of 89 degrees. For all practical purposes, the infant appeared to have been dead for at least 20 minutes. I was quiet for a moment, processing what Dr. Winters was telling me. A 24-week premature infant, unattended for 35 minutes, with no vital signs for at least 20 minutes. In my experience, this was not a resuscitation scenario. This was a tragic fetal death that would require grief counseling for the family and careful documentation for legal purposes. The paramedics initiated full neonatal resuscitation protocols. Dr. Winters continued. CPR, intubation, warming measures, epinephrine, the complete algorithm. They worked on her for 18 minutes in the field before achieving return of spontaneous circulation. 18 minutes of resuscitation, following at least 20 minutes of cardiac arrest, meant this baby had been without oxygen for close to 40 minutes total. Even for a full-term healthy infant, this duration of hypoxia would result in either death or catastrophic brain damage. For a 24-week premature baby, it should have been medically impossible to achieve meaningful resuscitation at all. They transported her here with ongoing CPR support, Dr. Winters said. When she arrived in our emergency department, her initial APGAR scores were as low as you can record and still be technically alive. Elena, that's not why I'm calling you. What do you mean? I asked, though something in Dr. Winters' tone was making me increasingly uncomfortable. After we stabilized her respiratory and cardiac status, we began our standard neurological assessment for extreme premature infants. Given the duration of cardiac arrest, we expected to find either no neurological responses or signs of severe brain damage. I waited, knowing that whatever Dr. Winters was about to tell me was going to challenge my understanding of neonatal medicine. Elena, this baby's neurological responses are not just normal for her gestational age, they're advanced, significantly advanced. She's tracking visual stimuli, responding to auditory cues, and demonstrating motor coordination that I've never seen in a 24-week infant. It's as if the 40 minutes of oxygen deprivation didn't happen. I felt that familiar sensation that every physician experiences when confronted with something that doesn't fit into established medical frameworks, a combination of skepticism, curiosity, and the uncomfortable awareness that you might be dealing with something beyond your current understanding. Rebecca, I need you to walk me through exactly what you're observing. When I test her pupillary light reflex, she not only responds normally, but appears to track the light source as I move it across her visual field. Though when I speak to her, she turns her head toward my voice with precision that suggests auditory localization abilities far beyond what's typical for her gestational age. When I touch her palm, her grasp reflex is remarkably strong and seems almost purposeful rather than purely reflexive. Dr. Winters paused, and I could hear the frustration in her voice. Elena, I've been practicing emergency medicine for 15 years. I've seen premature infants at every gestational age. What I'm observing in this baby doesn't align with anything I learned in medical school or residency. According to everything I know about neonatal development and hypoxic brain injury, this baby should be either dead or showing severe neurological impairment. Instead, she's more neurologically sophisticated than many full-term infants I've examined. I made the decision to accept the transport immediately, though I suspected that Dr. Winters was either overestimating the baby's responses or misinterpreting reflexive behaviors as purposeful neurological activity. It's a common phenomenon among physicians who don't specialize in neonatal care, the tendency to attribute intentionality to movements and responses that are actually involuntary reflexes.
We'll take her, I told Dr. Winters. I'm sending our most experienced transport team. They should be airborne within 20 minutes, and at your facility within an hour. There's one more thing, Elena, Dr. Winters said, her voice dropping to almost a whisper. The baby's mother, Isabella, regained consciousness about an hour ago when I told her that her daughter had survived despite the circumstances. She said something that I can't stop thinking about. What did she say? She said, I dreamed she was surrounded by light, that something was protecting her while I couldn't. Then she asked if the baby had been born with her eyes open, because in her dream, the baby was watching everything with old eyes in a new face. I felt an unexpected chill. In 22 years of neonatal medicine, I had heard many unusual stories from mothers about dreams and premonitions surrounding their babies' births. Most could be attributed to the emotional and physical trauma of premature delivery, combined with medications and stress. But something about the specificity of Isabella's description, old eyes in a new face, was unsettling in a way I couldn't articulate. Elena, when I examined the baby, after Isabella said that, I looked directly into her eyes. I know this sounds impossible, but it felt like she was looking back at me with an awareness that seemed. Dr. Winters struggled to find the words. Ancient, like there was someone much older looking out through those eyes. Our transport team, consisting of Dr. James Chen, our most senior neonatal transport physician, flight nurse, Patricia Kowalski, and respiratory therapist, Marcus Johnson, departed Phoenix Sky Harbor Airport at 7:15 p.m. I spent the 90 minutes waiting for their return, reviewing everything I knew about extreme premature infant care, hypoxic brain injury, and the neurological development timelines that should govern what this baby could and couldn't do. I also found myself researching case studies of infants who had survived prolonged cardiac arrest, looking for any documented cases that might explain what Dr. Winters had described. What I found was not encouraging. The medical literature contained scattered reports of premature infants surviving brief periods of cardiac arrest, usually 5 to 10 minutes, with varying degrees of neurological outcome, but I could find no documented cases of any infant, premature or full-term, surviving 14 minutes of oxygen deprivation without catastrophic brain damage. At 9:45 p.m., I received a call from Dr. Chen during their flight back to Phoenix. Elena, You need to prepare yourself for something extraordinary. I've been practicing neonatal transport medicine for 12 years, and I've never encountered anything like what I'm seeing in this baby. James, help me understand what you're observing. She's stable from a cardiopulmonary standpoint, better than stable. Actually, her oxygen saturations are higher than I would expect for an infant of her gestational age, and she's breathing over the ventilator with remarkable efficiency. But it's her neurological presentation that's unprecedented. Dr. Chen's voice carried the same tone of confused amazement that I had heard from Dr. Winters. Elena, this baby is making sustained eye contact. Not the random visual tracking you sometimes see in premature infants, but purposeful, directed eye contact that follows people around the transport pod. When Patricia speaks to her, she turns toward Patricia's voice. When I adjust her position, she seems to anticipate the movement and adjust her body accordingly. James, you know that premature infants at 24 weeks don't have the neurological development for purposeful visual tracking or coordinated motor responses. I know that, Elena. I've transported hundreds of micro-preemies, but I'm telling you, this baby's responses are more sophisticated than some full-term infants I've cared for. There's something happening here that doesn't fit into any medical framework I understand. Baby Sophia, as her mother had named her, arrived at Harmony Children's Medical Center at 10:20 p.m. I was waiting in our primary resuscitation bay with my full team, Dr. Amanda Foster, our chief neonatal fellow, nurses Sarah Martinez and David Kim, both with over 10 years of NICU experience, respiratory therapist Lisa Thompson, and Dr. Robert Nakamura, our staff pediatric neurologist, whom I had called in specifically to evaluate this case. The transport team wheeled baby Sophia into our unit, and I experienced something I had never felt in 22 years of neonatal medicine, a moment of complete disorientation as my medical training collided with what I was seeing. Baby Sophia weighed exactly 1 pound, 12 ounces, appropriate for her gestational age. Her skin had the translucent quality typical of extreme prematurity, and she required full ventilator support for her underdeveloped lungs. In these respects, she appeared to be exactly what I would expect from a 24-week premature infant, but her eyes were open, and she was looking directly at me. I need to be very specific about this observation because it's medically significant. Premature infants born at 24 weeks typically keep their eyes closed for the first several days or weeks of life. Their eyelids are often fused, their eye muscles lack coordination, and their visual cortex is too immature to process visual information meaningfully. When their eyes are open, their gaze is usually unfocused and random. Baby Sophia was not only looking directly at me, but as I moved around her warming bed, her eyes tracked my movement with precision that suggested visual processing abilities that shouldn't develop until much later in gestation. Dr. Vasquez, nurse Sarah Martinez, said quietly, "She's been doing that since she arrived. It's like she's studying everyone who approaches her bed." Dr. Foster leaned closer to examine baby Sophia's neurological responses. "I've never seen visual attention this sophisticated in an infant this premature. Look at this." She moved her pen light slowly across baby Sophia's visual field, and the infant's eyes followed the light source smoothly and deliberately. That level of visual tracking requires integration of multiple brain systems that aren't developed at 24 weeks, Dr. Nakamura observed. The visual cortex, the motor cortex controlling eye movement, and the attention networks needed to sustain focus on a moving object. This baby is demonstrating neurological integration that's more typical of a full-term infant. As we continued our initial assessment, baby Sophia began demonstrating responses that challenged every principle of premature infant development I had learned during my medical training. When I tested her Moro reflex, the startle response that helps assess neurological function, baby Sophia not only showed an appropriate response, but seemed to recover from the startlement more quickly than expected, almost as if she was consciously modulating her reaction. Her grasp reflex was remarkably strong. When I placed my finger in her palm, she gripped it with a firmness that was unusual for her size and gestational age. But more puzzling was what happened when I tried to withdraw my finger. She seemed to consciously release her grip rather than maintaining the involuntary grasp typical of premature reflexes. Most disturbing was her response to auditory stimuli. When machines beeped or when we spoke, baby Sophia would turn her head toward the sound source with a precision that suggested auditory localization abilities far beyond what's possible at 24 weeks gestation. But it wasn't just the accuracy of her responses, it was the apparent selectiveness. She seemed to respond more strongly to human voices than to mechanical sounds, and her responses to female voices appeared different from her responses to male voices. "Elena," Dr. Nakamura said, pulling me aside after observing baby Sophia for 30 minutes. "I need to be direct with you. What I'm seeing in this infant's neurological presentation is medically impossible. The integration of sensory processing, motor control, and attention that she's demonstrating requires brain development that occurs weeks or months after birth, not before." We immediately ordered the most comprehensive neurological and developmental assessment available, brain ultrasounds to check for structural abnormalities, bleeding, or signs of hypoxic injury, continuous EEG monitoring to assess brain wave patterns and electrical activity, blood tests to check for genetic markers, metabolic disorders, and biochemical indicators of brain cell death, MRI scanning to provide detailed images of brain structure and development. The results were as confusing as baby Sophia's behavior. Her brain ultrasound showed normal structure for her gestational age, with no signs of bleeding, swelling, or the kind of damage we would expect after prolonged oxygen deprivation. The brain tissue appeared healthy and appropriately developed, with no evidence of the cell death that should have resulted from 40 minutes of cardiac arrest. Her EEG patterns were even more puzzling. Instead of the disorganized, immature brain wave activity typical of 24-week infants, baby Sophia showed organized sleep-wake cycles and electrical patterns that were not only normal, but appeared more mature than expected for her gestational age. Most remarkably, her blood work showed no elevation in the enzymes and proteins that typically indicate brain cell death after hypoxic injury. Her levels of neuron-specific enolase, S100 protein, and other biomarkers of brain damage were actually lower than normal ranges. It was as if her brain had been completely protected during those 40 minutes without oxygen, or as if the cardiac arrest had never occurred at all. "This doesn't make medical sense," Dr. Nakamura told me after reviewing all the test results. "According to every diagnostic tool we have, this baby's brain not only survived 40 minutes of oxygen deprivation without damage, but appears to be developing at an accelerated rate compared to normal gestational timelines." Isabella Moreau arrived at our hospital the following morning, having been cleared for discharge from Desert Valley General. She was a striking woman with long dark hair and paint-stained fingers, someone who looked like she spent more time thinking about colors and textures than medical diagnoses. When I met with Isabella to discuss baby Sophia's condition, I found myself in the unusual position of delivering news that was far more positive than any medical logic could explain, while simultaneously trying to understand what had happened during those critical hours when her daughter was born. "Mrs. Moreau, your daughter is currently stable and showing remarkable neurological responses for her gestational age, but I need to understand exactly what you remember about her delivery and the circumstances surrounding her birth." Isabella sat quietly for a moment, looking toward the NICU where baby Sophia was being cared for. "Dr. Vasquez, I know this will sound strange, but I remember very little about the actual delivery. I was working in my studio, painting a commission piece, when I suddenly felt like I was falling. Not physically falling, but falling through time or space, or something I can't describe." She paused, clearly struggling to find words for an experience that resisted description. "The next thing I remember clearly is waking up in the emergency room in Flagstaff. But during the time I was unconscious, I had the most vivid dream or vision I've ever experienced." "Can you describe what you dreamed?" I saw Sophia being born, but not from my perspective. It was like I was watching from above, seeing both of us on the floor of my studio, and there was this light surrounding her, not bright light like a lamp, but something warm and protective that seemed to be keeping her safe while I couldn't. Isabella looked directly at me, her eyes intense with the memory. In the dream, I could see that she wasn't breathing, that her little body was too still, but the light was somehow breathing for her, keeping her alive until help could arrive, and her eyes were open the entire time, watching everything with this expression of complete awareness. Over the following week, baby Sophia continued to confound every expectation and protocol we had for managing extreme premature infants. While most 24-week babies require weeks or months of intensive respiratory support, Sophia was breathing over her ventilator so effectively that we were able to reduce her settings ahead of our normal timeline. By day 3, she was showing coordinated sucking and swallowing reflexes that don't typically develop until 32-4 weeks gestation. By day 5, she was demonstrating sleep-wake cycles that were more organized and predictable than most full-term infants. But the most remarkable change was in her apparent awareness and interaction with her environment. Baby Sophia would lie in her incubator, with her eyes open for extended periods, seeming to observe the activity around her with an intensity that was both fascinating and deeply unsettling. When her mother visited, she appeared to recognize Isabella's voice and would become visibly more alert and active when Isabella spoke to her. More disturbing to me, as her physician, was her apparent recognition of individual staff members. When I approached her bedside, her responses were different from when other doctors examined her. When Nurse Sarah Martinez worked with her, baby Sophia seemed calmer and more cooperative than with other nursing staff. It was as if she was forming preferences and relationships based on repeated interactions, cognitive abilities that shouldn't be possible at her developmental stage. Foster began documenting these observations in detail, creating a record of behaviors and responses that had no precedent in neonatal medical literature. Elena, I've been keeping detailed notes on Sophia's interactions, and there's definitely a pattern of recognition and preference that's unprecedented for her gestational age. She's not just responding to stimuli, she's learning and adapting based on experience. By the end of that first week, I had consulted with pediatric neurologists, neonatologists from major medical centers across the country, and researchers who specialized in infant brain development and hypoxic injury. I shared baby Sophia's case history, diagnostic results, and behavioral observations with experts at Children's Hospital of Philadelphia, Boston Children's Hospital, and the National Institutes of Health. None of them could provide an explanation for what we were observing. Dr. Patricia Williamson, a leading researcher in infant consciousness at Harvard Medical School, reviewed our documentation and called me personally. Dr. Vasquez, I've been studying infant neurological development for 25 years, and I've never encountered a case that challenges our basic understanding of premature brain function like this one. If your observations are accurate, this baby is demonstrating cognitive abilities that rewrite what we think we know about consciousness in extreme premature infants. But what happened in week 2 would be so far outside the realm of medical possibility that it would ultimately drive me to question whether we truly understand anything about human consciousness, infant development, or the boundaries between life and death. What I witnessed next would challenge not just my medical training, but my fundamental understanding of what it means to be human. Baby Sophia was about to demonstrate abilities that no premature infant should possess, and reveal something about consciousness that would haunt me for the rest of my career. What happened on March 23rd, exactly 2 weeks after baby Sophia's birth, shattered every foundation of medical knowledge I had built over 22 years. I was making morning rounds when Nurse Sarah Martinez called me urgently to Sophia's bedside. "Dr. Vasquez, you need to see this immediately. Baby Sophia, who should have been a 26-week premature infant, barely capable of basic reflexes, was sitting upright in her incubator, not leaning against supports, sitting independently, with perfect spinal control that doesn't develop until months after full-term birth. But that wasn't the most shocking part. She was looking directly at me, and I swear on everything I hold sacred, she smiled. Not a reflexive grimace or gas-related expression, but a deliberate, conscious smile of recognition. "Good morning, Doctor Elena," she said in a voice that was impossibly clear for an infant who shouldn't have developed vocal cords capable of speech. The entire NICU fell silent. Every monitor, every alarm, every conversation stopped as staff members turned to witness something that violated every law of human development. Over the next hour, baby Sophia spoke with the vocabulary and consciousness of someone far older. She told us her name was actually Sophia Elena Moreau. She had chosen her middle name to honor me. She explained that she had experienced every moment of her cardiac arrest, but had been protected by something beyond medical understanding. "Dr. Elena," she said, her impossibly wise eyes meeting mine, "I was sent back for a reason. Some souls choose difficult beginnings to teach others about the mysteries of consciousness." She described her mother's paintings with perfect detail, mentioned conversations that had occurred while she was supposedly unconscious, and spoke about medical concepts that no infant could possibly comprehend. Dr. Nakamura ran every neurological test available. Brain scans showed normal premature development, yet here was an infant demonstrating cognitive abilities decades beyond her chronological age. Within hours, however, Sophia began to fade back into typical premature infant behavior. Her speech became babbling, then silence. Her motor control regressed to age-appropriate reflexes. By evening, she was once again a normal 26-week premature baby, requiring full intensive care support. But she had left us with a gift, absolute proof that consciousness operates beyond our medical understanding. That night, I went home and wrote my resignation letter. How could I continue practicing medicine when I had witnessed something that challenged every principle of human development? Baby Sophia survived and thrived, growing into a healthy child with no memory of her impossible awakening. But her mother Isabella kept a detailed journal of that day, documenting every word Sophia had spoken. I now work as a medical writer, researching consciousness and near-death experiences. Sophia's case has been studied by researchers worldwide, though no one can explain what happened. Sometimes I wonder if we understand far less about human consciousness than we think. Baby Sophia taught me that the boundary between possible and impossible is much thinner than medical school ever suggested. Every day, I think about what Sophia told me during those brief hours of impossible awareness. She said some souls choose difficult paths to expand human understanding of consciousness itself. Maybe that's exactly what she did. The case of baby Sophia remains the most documented and studied example of impossible infant consciousness in medical literature. But for me, it represents something far more profound, proof that human awareness operates in ways we're only beginning to understand. What do you think happened to baby Sophia? Have you ever experienced something that challenged your understanding of consciousness? Share your thoughts in the comments below.